Bienvenue à HAAOT 2020. Cela a été un printemps fou. Nous sommes très heureux de pouvoir nous réunir pour notre conférence. Même si nous ne pouvons pas être ensemble en personne, nous pouvons encore apprendre beaucoup en utilisant Zoom. Cette rencontre est le résultat du travail acharné de nombreuses personnes dans trois pays. Je tiens à remercier toute notre équipe travaillant en Haïti, en Angleterre et aux États-Unis pour préparer notre matériel et organiser notre rencontre ensemble. Je voudrais également remercier la Fondation pour les traumatismes orthopédiques d'avoir fourni de l'argent pour payer une traduction professionnelle en français. Comme vous pouvez le constater, mes pauvres mots n'ont pas été traduits par des professionnels. J'espère que vous me pardonnez d'avoir parlé comme une néandertalienne. Bienvenue.
Good afternoon, everybody. I will have to speak in English because George speaks in French. Okay. Bienvenue à tous et merci beaucoup à vous tous. Merci beaucoup au groupe de HAAOT. Merci beaucoup au groupe qui est en Angleterre. Merci beaucoup au groupe qui est aux États-Unis, surtout à Massachusetts. Et c'est pour la 7e ou la 8e fois qu'ensemble, HAAOT organise un cours pour que tout le monde puisse ensemble faire progresser l'orthopédie et surtout l'orthopédie en Haïti et avoir un tout petit peu d'échange et non pas de technologie, mais de méthode entre les divers pays qui participent à ce cours. Mon contentement est qu'aujourd'hui, après quelques années, tous les orthopédistes et tous les aspirants orthopédistes haïtiens, c'est-à-dire tous ceux qui sont en résidence, en formation, participent à cette conférence de HAAOT. Je vais parler principalement de ceux qui sont à l'hôpital de l'Université d'État d'Haïti, ceux qui sont au Cap haïtien justinien et que ceux qui sont à Port-au-Prince à la paix. Donc, je pense qu'ensemble, quand nous mettons ensemble, nous pouvons réaliser de grandes choses et grâce à la coopération et à l'échange de technologies et de connaissances, nous pouvons faire avancer l'orthopédie en Haïti. Merci à vous tous qui participez ici et merci surtout à ceux qui ont commencé ce programme après le 12 janvier 2010. Regretter mémoire au point de vue de date à célébrer, mais qui a pu donner quand même un nouveau début, un nouveau commencement à l'orthopédie en Haïti. Et vous tous, bonne conférence. Merci beaucoup.
Thank you so much.
So this first section is
Cette
about soft tissue management. And our first presenter is Dr. Isaac Archulus.
À mon nom personnel et au nom du service d'orthopédie de la HAAOT, Je salue chaque participant à cette série de présentations virtuelles.
I say hi to everybody in this presentation.
Et je remercie aussi les initiateurs de cet
I
événement.
want to thank the people from HAAOT.
Je suis heureux de vous entretenir aujourd'hui au sujet de la greffe de peau,
I want to talk about
particulièrement
skin
dans
graft
l'utilisation de dermatomes.
using a
On va
dermatome.
utiliser un cas qu'on a eu au service d'orthopédie pour faire
It was
cette
a case we
présentation.
had in the department
Ouais.
to do that.
Voici le plan qu'on va utiliser pour cette présentation.
This is the
La
plan
greffe
we're
de
going to use.
peau est une intervention chirurgicale qui permet de prendre de la peau d'un endroit du corps afin de la mettre à une autre partie du corps. Cette pratique a été mise en place en 1969 par Jacques-Louis Reverden et cette pratique aide beaucoup dans la prise en charge des scars, des boules profondes et aussi dans la prise en charge des fractures ouvertes avec perte de substance. Okay? On a commencé à utiliser un dermatome pour faire la greffe de la peau en 1930. Donc, on va commencer tout de suite avec la présentation de la patiente. C'est une femme de 33 ans, GZO-PZO. Elle est célibataire, infirmière de profession, sans antécédent particulier. Elle a été victime d'un accident de voiture le 30 décembre 2019, ce qui a entraîné une amputation du pouce droit et aussi un dégradement de la base du pouce. Okay? Vous voyez les images, ça c'est l'image à l'arrivée, la radiographie à l'arrivée aussi. Là, c'est lorsqu'on a commencé à prendre en charge la patiente. Okay? On a utilisé ces matériels-là pour faire la greffe de peau après que la patiente a commencé à granuler. La plaie a commencé à granuler. Okay? Et après qu'elle a été installée en équipe dorsale, on a préparé le site d'honneur qui était la cuisse. On a fait infiltration locale de la cuisse avec 6 cc de lidocaïne 2%, dilué de 4 cc de normale saline. On a fait des prélèvements de peau mince avec une lame de rasoir stérile. Et puis, on a déposé les petits fragments de peau au niveau de normale saline. Okay? On a fait un bloc anesthésique loco-régional du nerf radial et médian au niveau du poignet droit. Ensuite, on a lavé le site receveur et on a commencé à étaler les fragments de peau. On a utilisé des aiguilles de seringue pour mieux étaler les fragments de peau. Ensuite, on a déposé de la gaz vaseline dessus. Ensuite, on a déposé de la gaz stérile en duvet et on a fait le pansement. Ensuite, on est retourné au site d'honneur pour faire le pansement et on a mis avant de la gaz vaseline. Ensuite, on a fait le pansement. Okay? Donc, l'intervention a terminé et a duré environ 1 heure et le saignement a été minime. Donc, ça, c'est une image en pair-up de la greffe lorsqu'on a fini d'étaler de manière méticuleuse sur la peau sur la plaie. Donc, ça demande de la patience et aussi d'être méticuleux. Donc, c'est le premier pansement qu'on a fait après 10 jours. On voit là comme la greffe commence la greffe a réussi, ça commence à fonctionner. Et puis là, c'est la cuisse, et ça a cicatrisé. Okay? Ça, c'est la cicatrisation complète après environ 2 mois. Ça, c'est en avril. Ça, c'est une image qu'on a eue en début de juin. Et ça, c'est en mai-juin. Là, elle commence à fonctionner. Elle est fonctionnelle, elle fait la flexion et elle ferme normalement la main. Et l'opposition du pouce. L'opposition de la main est plus ou moins faite, mais elle n'a pas complètement, elle ne ferme pas complètement la main. Elle peut normalement tenir un objet dans la main. Et comme complication, elle a développé une kéloïde au site d'honneur. Donc ces complications sont liées à notre patient, pas forcément à tous les greffes de peau faites sur des dermatome. C'est spécifiquement notre patient, c'est une kéloïde qui a développé au site d'honneur Elle a aussi développé une ostéoporose de nos fonctionnements et aussi une raideur résiduelle au niveau du deuxième doigt. Okay? En conclusion, nous disons qu'avec une dermatome, le temps opératoire serait réduit et la cicatrisation serait plus esthétique. Mais avec la lame de rasoir, il était possible aussi de fixer la peau après la greffe, car les fragments sont trop petits et trop nombreux. Cependant, en situation de précarité, avec une lame de rasoir, on a pu offrir une bonne greffe de peau qui a permis à la dame de reprendre ses fonctions le plus vite que possible. Toutefois, on espère trouver et pour elle une orthèse pour améliorer l'opposition. Okay? Et puis, on travaille ensemble avec le service de dermatologie de l'hôpital pour prendre en charge sa kéloïde et avec le service de physiothérapie pour améliorer la raideur résiduelle au niveau du deuxième doigt. Donc, et voilà les références qu'on a eues. Ça a été un plaisir et de vous entretenir. Merci pour l'attention que vous m'avez accordée. Maintenant, faisons place aux questions et aux suggestions et ce sera un plaisir d'entendre les suggestions et aussi les questions et là-dessus. Merci beaucoup. Merci pour l'attention.
Thank you so much. He also has two just really quick recovery videos that he wanted to show of this patient that he was speaking about. I'll just quickly share those.
Donc ça, c'est une vidéo qu'il a postée et après, qu'il voulait juste montrer un support de la greffe qu'ils ont fait et la réussite qu'ils ont eu. C'est une deuxième vidéo du patient avec en train d'écrire.
Great. Sorry, we're still learning. This is our first time, so we're trying to kink out.
On est toujours en train d'apprendre, donc s'il y a des petits glitches et ça pourrait marcher aussi.
All right. Thank you very much. Now we go next to Dr. Fred Duffy. It's good to see you, Fred.
Good to see you, George. Like the background.
Dr. Duffy, go ahead.
I'll let everybody know where I really am. Ready? I'm inside my car, in my driveway. That's where I really am. But I'll class it up for you all.
I love it. Dr. Duffy, I'm going to play a recording. Is there anything you'd like to say before I start it for you?
No, Taylor, I'm happy to answer questions afterwards. And
yeah, we'll do the Q&A right after.
We'll play it and see if everybody can follow.
Okay, great.
Hi, this is Dr. Fred Duffy in Dallas. I'm happy to be involved with the HAAOT course again. I've spoken in Port-au-Prince multiple times. I'm sorry we're not there in person, but this will have to do for now. I've shortened my talk that I've given over the years. I believe I'm talking in the first session and maybe even the first talk. So welcome to everybody. And I'm excited to be here. We're going to talk about soft tissue issues and orthopedic injuries. And so I'm going to ask you all to think like a plastic surgeon. I'm going to note here on my cover slide here that we have, I'm very excited to share that we've started a Ministry of Health plastic surgery training program at Haiti with our first plastic surgery fellow. And we'll talk more about that hopefully later in the course. I'm a busy reconstructive surgeon in Dallas. I've been coming to Haiti for years, and you'll be able to reach me going forward if you have specific questions. Every wound is different. Everybody in Haiti, if you're a surgeon, has dealt with wounds, whether it be exposed hardware, this is a dog bite, and this is sarcoma. This is a patient that I just operated on today. After his resection, this is the anterior surface, and this is from the side, and he's been radiated to start. That's the olecranon that's exposed, and so it always is a question of how do we cover a patient to maintain form and function. In Haiti and in the United States and around the world, we'll spend a lot of time talking about fractures in this talk. Most of you know your outcomes are going to be dependent on several things. What's exposed, what's involved, how much periosteal stripping there is in the bone. But that soft tissue disruption is key, and you all, like every orthopedic surgeon in the world, deals with that. Timing is very important. This is a patient up in Cannes that I dealt with right after the earthquake 10 years ago, and the fibula was exposed, and they tried drilling it out, and obviously it didn't work, and that whole fibula is dead. So you need to get coverage sooner rather than later. It's important to define the defect, and that means, you know, what is all the tissues around the defect viable? How big is it? What are the comorbid issues? Does the patient have diabetes? Is there vascular disease? Has there been prior radiation therapy? You name it. And then there's special areas that we have to consider when we talk about covering. But there's a lot to understanding what the defect is you're trying to cover, and you need to know that before you come up with a surgical plan. Wound preparation, patient preparation, do what you can to get the patient healthy and get that wound debris. We've come a long way in Haiti, and my years are coming down there with serial debridements. That's key. A wound needs to be ready to close before you close it. That's an important concept. This is the most important slide maybe in the whole talk. You guys can do a great job of reducing a fracture, plating it. But if there's soft tissue disruption and the soft tissue envelope is not intact, you're going to have a problem, and particularly long bones like the tibia. Options, I think one of the residents is going to talk about skin grafting, and another one's going to talk about the VAC. There's a whole host of things that we do. I'm going to show you just a little bit later a free flap that I've done, and also a perforator-based flap. I want to stress and work and focus my energies on what we can do in Haiti. Though microsurgery has started at Mirbelet, and we're going to continue that going forward. And this is key. It's key in Haiti. It's key everywhere. Use the simplest approach you can to get your wound covered. You don't want to be doing a big complicated operation and taking up overtime when there's a simple way to close something. I want to show you a medial gastrocnemius flap. I'm going to challenge all of you that each of you should be able to do this operation. It's a workhorse in lower extremity reconstruction around the knee. This is a total knee revision arthroplasty that the orthopedic surgeons called me about a couple of years ago. That's after debridement, so get that wound ready. There's a good example. Right below the patellar tendon there is the hardware. And medial gastrocnemius flap is easy to draw out. It's a very easy flap to dissect. You make an incision from the eventual defect down towards the Achilles. I do most of my dissection with my finger. You dissect out the belly, you release the median raphe between the medial and lateral heads, try and preserve the sural nerve and the lesser saphenous vein. You can score this fascia that you see there and extend the length of the flap. And that's the flap inset. You just do a skin graft to finish it up. It's a great, great flap, and it's something you all should be able to know how to do. But let's talk about now a couple of these cases I showed earlier. How do you fix that? You can do a local skin flap, but unless you delay that flap, which is a basic time-tested principle in plastic surgery, the flap will probably die. So you can Doppler out some perforators that supply that bipedical flap you're going to develop. You make your incision, elevate the flap, tack the flap back down. Wait a week, 10 days. Sometimes you can do multiple delays. Advance the flap, skin graft the donor site, and that worked beautifully in this elderly gentleman. This woman was bitten by a dog. She's got an exposed tibia and actually distally there, the fibula. And I used a free flap, an antilateral thigh free flap to cover the tibia, and it's just a perforator-based flap to cover the fibula, a local flap. The ALT flap is a workhorse in my practice. We've done a couple in Haiti at Mirabelais, and it's a very easy flap to dissect once you've gotten the hang of it. Perforator flaps involve trying to save that muscle and all the nerves before you transfer the tissue. So that's the patient after her surgery. That's ALT flap proximally. I skin grafted the donor site where I took the flap distally to cover the fibula. I think this is the last flap I have to show. This is a propeller flap. And I put this at the end of the talk because propeller flaps can be done in Haiti. This is a case that was not my case. This is Marco Innocente. He's a fairly famous plastic surgeon in Florence, Italy. I went to visit him. This is a recurrent sarcoma resected at the ankle. The patient was radiated. Because of the tumor involvement, the posterior tibial nerve was sacrificed, which made Marco's work easier. So there's the flap being dissected, and you'll see proximally there's a perforator and distally there's a perforator coming out through the deeper tissues. This is done under tourniquet control. Distally is a neurovascular bundle, the posterior tibial vessels and the posterior tibial nerve. And what Marco did was he incised this up. He lifted that flap up on one perforator. And then it's called a propeller flap because the flap is turned like a propeller. We twist around, and amazingly, that artery and vein rate will tolerate a 180 degree twist. So it's borrowing from Peter to pay Paul. It's rotating the flap around, twisting the flap around. And that can be done with just a Doppler and a tourniquet, and very easily in Haiti and under-resourced countries because we have the technology. It's all about anatomy and learning your anatomy. That's it. I've tried to limit this to 8 or 9 minutes. Hopefully I've done that. I'm going to challenge you all to think like a plastic surgeon. I'll be available for questions, obviously, at the end of this. And also available with the email address below. I take consults from Haiti all the time in Dallas. I look forward to getting to meet some of you in the future. I look forward to inviting Willie to meet all of you as we build plastic surgery capacity in Haiti. Thank you, and enjoy the rest of the course.
I believe we have some time allotted for questions now. Is that correct?
Yes, we do.
And while we have Dr. Duffy on the line, let's ask him questions if anyone has one.
Thanks, George. As the questions are coming in here, but Willie Phil Jean-Louis is on the call or on the meeting, and we have started plastic surgery training at HUM in Mirabelais, and we're very excited about it. And I hope eventually next year that we're giving this talk in Haiti, and Willie will give the talk. So if anybody wants to get in touch with Willie, reach out to me at that email address, and after the course, I'll get you in touch with Willie.
Donc, s'il y a des questions pour le docteur Archelius ou pour le docteur Duffy, vous pouvez poser des questions. Vous pouvez poser des questions soit sur le chat room ou bien vous pouvez poser des questions directement en mute votre micro. You can ask questions either on the chat room or you can just ask questions directly to Dr. Duffy or Dr. Archelius pour les deux présentations qu'on vient de faire pour la première partie de la conférence. For the first conference. So there's a question in English, actually. Dr. Duffy, I have one question. Would you perform the propeller flap for a patient who smokes and has diabetes?
You can try. You can try. They're versatile. and if you have another option, it's a reason you can try. That's all I can say. And, it's probably preferable to use a propeller flap or a local flap than some sort of free tissue transfer.
Ok, est-ce qu'il y a d'autres questions pour le docteur Duffy ou le docteur Chelus? Ok, Dr. Péan, go ahead.
Question. Thank you for Dr. Duffy, the presentation. In regards to communication with the patients, how much do you emphasize on the patient's expectations for the end result of what you're offering them?
Well, we talk a lot about expectations and the fact that even adequate soft tissue coverage might not work. It's funny you asked that. I have a patient that I spent about a month covering their lower extremity trauma after a motorcycle accident here in the States, in Dallas, about 8 or 9 months ago. Did a free flap and got her tibia covered and multiple skin grafts. And she'd also had a hip fracture and a pelvis fracture and needed to have an ankle fusion. And she was having chronic pain. And after about 9 or 10 months, she just decided to have a BK, a below knee amputation. So you have to talk about expectations and some of the downsides of big major injuries. I hope that answers your question.
Exactly. That was the point I wanted to pinpoint, basically regarding the amputation, since it's a very sketchy subject back here. How to approach it, how to tell the patient that it might end up at amputation. Very, very often they'll come to you and tell you this is enough, perhaps like your patient. So is there any tips and tricks on the psychology of those really bad wounds that based on experience might end up in those amputations?
Well, if the posterior tibial nerve is out and the patient's in sensei, I will not reconstruct the patient. That's the main thing. And you have to consider resources and physical therapy, external physical therapy, as y'all know from hand surgery and even lower extremity surgery. It's very, very key. And without that, sometimes amputation is the better option. Having said that, in Haiti, without the access to good prosthetics, that's an issue as well.
Thank you, sir. I'm happy to see a lot of friends here. Thank you.
Sure.
Ok, s'il y a d'autres questions pour les deux présentateurs, on peut les poser. Et maintenant, on peut le faire en français ou en anglais. Ceux qui veulent le faire en français, je ferai la traduction directement et vice-versa. Il faut juste lever la main et unmute la vidéo.
Dr. Woolley, did you want to just give a summary of Dr. Duffy's response to the questions?
Oui, donc Dr. Péan avait demandé. Dr. Péan, tu peux traduire toi-même directement ou bien tu veux que je fasse? I have Dr. Péan write it down. Donc il a demandé pour la topographie du patient, est-ce que ça marche pour les flaps, ça marche pour tous les patients? Et est-ce que le contexte de diabète, etc., c'est dans un contexte où ça peut aboutir à une amputation? C'est ce que j'ai compris de la question. Et le Dr. Duffy a dit que bon, ça dépend du patient. Dr. Péan, vas-y.
Tu peux terminer si tu veux, désolé. Vas-y.
Non, c'est ça. C'est-à-dire que Dr. Duffy a répondu que effectivement, c'est pas assez indépendant. Et que bon, en termes d'atteinte, il faut le faire de toutes les manières pour pouvoir sauver le monde, mais l'amputation ne sera pas forcément exclue dans le truc. Il faut juste parler au patient et expliquer que c'est une tentative et ce n'est pas forcément un résultat définitif. Je ne sais pas si on veut ajouter quelque chose d'autre.
Très bien, merci.
Il n'y a pas d'autres personnes qui veulent poser des questions pour ces deux panélistes? Actually, I have one question. Dr. Duffy, for the propeller flap, and I'll translate this in French in a few minutes. What is the rate of this flap dying? Because you're flipping it over, and it's a perforator. It's a very small vessel, and you can contract, it can clot or anything like that. And so, what is really the rate of success for such a big flap in the leg?
It's a hard question to answer, Pierre. The case that I showed you, the success of that is partly a function of, if you consider the posterior tibial neurovascular bundle, that because of the sarcoma, his posterior tibial nerve had been divided in the resection. So that gave Marco more freedom to flip the flap around. It's amazing that more don't die, but it depends on the patient. The question that the prior gentleman just asked was a good one about diabetes and AIDS and vascular disease. But the more you have to turn it, the more likely you're going to have problems.
Donc, la question était tout simple. I'm going to translate to the French now, just for a few seconds.
Sure.
Donc, la question c'était, quand vous faites le propeller flap, quels sont les risques que cette perforante se bouche ou bien soit complètement tournée et il n'y a pas de vascularisation qui arrive et que le flap meurt. Et il te dit que, bon, dans ce cas, c'est un cas spécifique dans le cas d'une tumeur, mais effectivement, le risque existe. Et si le patient a des comorbidités assez élevées aussi, ça ne peut pas forcément marcher, mais c'est une option à considérer. Any other questions? Est-ce qu'il y a d'autres questions pour les deux premiers présentateurs? Ou bien... Taylor, if you want, we can probably go to the second round and then have questions later, if Dr. Dar is okay with that.
Okay. Our next presenter will be Dr. Christina Desjons.
La prochaine présentation, c'est Dr. Christina Desjons.
Good afternoon. My name is Christina Desjons from University of La Paix Hospital, and I am honored to be presenting you a prospective observational study on the advantages of a new low-cost negative pressure wound therapy using a turtle vac. And we'll be presenting, first of all, what is negative pressure wound therapy, then the new turtle vac, followed by some interesting cases. So the high cost of healthcare and limited available resources are two compounding problems affecting patients of lower socioeconomic status around the world. And one specific obstacle we face is wound management following trauma or surgical correction. And this includes the direct cost of wound care, limitation in staff, and resource utilization. And nowadays, there has been a general uptrend of technology, which has also led to an associated increase in cost. And one such product is negative pressure wound therapy using the vacuum-assisted closure. So the aim of this report is to describe the turtle vac as a novel low-cost device, not depending on wall suction, which could provide an affordable treatment for doctors and nurses to aid patients with traumatic delayed wounds in a resource-poor setting. So the VAC therapy has many advantages, like treatment of complex wounds, whether they're acute or chronic, and it serves as a bridge to definitive closure when primary is not possible, but it costs more over a prolonged use. And the VAC has a unique mechanism of action in which one has a distribution of negative pressure localized using a sponge or gauze. So it maintains an environment that promotes healing, but also stimulates physiological responses important for healing. These responses are either on the tissue or cellular level. Therefore, it brings the edges of the tissues closer together, minimizing the size of the tissue defect. It reduces infection, it decreases edema, and increases infusion. There's also a phenomenon called the microstrain that actually stimulates cell proliferation, angiogenesis, and granulation tissue formation. So these are two interesting articles. The first one in 2008 comparing the VAC treatment and the conventional treatment on diabetic foot, and it demonstrates an improvement in healing rates and an overall lower cost of care in the VAC group. And the second study showing the mean time of drainage on a hematoma is less with the VAC group than the regular dressing, and also has a low infection rate. So the VAC would be considered a more dominant intervention when compared with traditional dressings because it's less costly and more effective. And in 2007, a new device called a CureVax, which is a pressure stabilizer connected to a wall vacuum cleaner, was created in the University of Sao Paulo in Brazil. And they were actually the first to conduct a randomized prospective study comparing the traditional vac. So in their article, the USP system with a less healing time has proven effective, but it's not inferior to the VAC system, which itself is 70 times more expensive. Therefore, in a public hospital, this difference can lead to huge saving in resources. So the Turtle Vac is designed and constructed by Dr. Cobbs and was first used in Haiti after the earthquake in 2010. But a study could not be done because of the patient he had lost sight of. And besides its numerous advantages, one disadvantage to be noted is that the patient is actually unable to leave a certain vicinity as the vac needs a constant electrical source. It is important to know the specific indication of a turtle vac because it is not a cure-all. And it can be used for acute, chronic, simple, or complex wound, fasciotomy wounds, and infected wounds. It is also important to avoid using the turtle vac on necrotic tissue or foreign body, or if the patient is uncooperative. And the patient needs to have adequate circulation on the involved limb for best results. So this is a case series involving 23 patients managed with negative pressure wound therapy with the turtle vac. All fibrotic tissues were excised and wound contraction evaluated. Wound changes were done every 4 days and wound was cleaned with saline water or Dakin solution every time. The average follow-up was of 1 year. So the turtle vac is a device based on an aquarium pump, and we use canisters and suction tubes attached to the pump and going to the patient. The vacuum actually generates its own suction with 5 to 8 inches of mercury, and it's not relying on the hospital well system. So it can be left at the patient bedside. And for the wound, we use a kitchen sponge, which are boiled for 10 minutes, and food wraps as occlusive drapes. Also airline tubing and nasogastric tubes connecting to the canister and to the patient's wound. So most patients were male with a median age of 34, and the mechanism of trauma was road traffic accidents. So with our turtle vac, granulation tissue started to appear after the second dressing change, and the wound contraction estimated around 15 days, and a ready for surgery condition around 10 to 11 days. Our first case is a 34-year-old male presented 1 year following a motor vehicle accident with failed non-union. And a staged masculine technique was performed for him, but the patient was lost to follow-up. He came back 21 days later with a post-op anterior wound dehiscence, and a local debridement and cement spacer were removed with a rotational full thickness flap performed to cover the lost tissue. The patient was then discharged 5 days later, and standard dressings were done by nurses, but with no improvement, and flap failed 2 weeks after. So the patient was readmitted with negative pressure wound therapy. We started with that treatment. Dressing changes occurred every 3 to 4 days, at which time the wound was clean with Dakin solution, making sure to debride any fibrous tissue. And granulation tissue was found on day 3, doing first dressing, and wound contraction happened 20 days after. So the turtle vac was left for additional 5 weeks until skin leveling occurred, at which time the patient was transitioned to traditional dressings. And 9 weeks later, the patient was presented with complete closure of the wound. Second case is a 65-year-old patient with an ischemic distal anterolateral wound of the tibia after an animal bite and has been doing wound care at home for the past year. So she benefited from irrigation and debridement, and we found that she had a necrotic anterior cortex. So the necrotic tissues were debrided and negative pressure wound therapy initiated to promote granulation tissue since bone was already dead. And this is after 3 weeks of negative pressure wound therapy. We then perform an osteotomy of the interior third of the cortex of the tibia, followed by a cross leg flap and skin graft. And this is 3 weeks after the pedicule was released. And this is her now. Third case, a 28-year-old polytrauma patient sustained a head injury with a closed midshaft femur fracture and an open type 3B bimalleolar fracture and midshaft tibia associated with an ACL and MCL rupture. So he came to our facility 1 week after. We then started debridement and irrigation and also negative pressure wound therapy with the turtle vac. And also a femoral IM nailing, cerclage of bimalleoli, and debridement. So the wound care was done every 3 to 4 days with saline water, and the patient benefited from tibial IM nailing just after 3 weeks of negative pressure wound therapy. Fourth case, another 23-year-old female patient with a neglected infected open fracture of the first ray of the foot associated with a dry gangrene of the second toe after motor vehicle accident. She lost her tib ant and extensor alicis longus. So we went in OR for extensive debridement and irrigation of the wound, immobilization of the foot with X-Fix, and the negative pressure wound therapy. So this is the wound just 3 weeks after negative pressure wound therapy. Wound care was done every 3 days with saline water. And 3 weeks after negative pressure wound therapy, she benefited from a cross leg flap. And this is 3 weeks after the cross leg flap. It was incised 10 days after. Fifth patient, a 20-year-old female, again with midshaft fracture of the tibia associated with an infected posterior lateral wound after motor vehicle accident. She was admitted and we performed extensive debridement, negative pressure wound therapy, and external fixation of the tibial fracture. So the first picture demonstrates the wound, 6 days of negative pressure wound therapy with granulation tissue present, and the wound was cleaned with saline water every 3 to 4 days. The second picture shows the wound after 14 days of negative pressure wound therapy. At that time, we decided to skin graft the wound, and the last picture shows her leg 1 month post-op. So the difference was not significant compared to commercial VAC, but it was significant compared to regular dressings. The cost of treatment was significantly lower. No complications were observed, and the patient only needed to buy the remaining parts for dressing changes as gauze and sponges. So our system also should be used for no more than 2 wounds in a single patient. And the CURATE study illustrates the utilization of a new low-cost portable negative pressure wound therapy in a resource-poor public hospital of like Hospital of La Paix. And this new device, in our experience, appears comparable to commercialized VAC for the treatment of complex traumatic injuries, potentially providing an efficient and important treatment modality for a clinical setting. The turtle vac should be considered as a supplement to current negative pressure wound therapy methods for patients and physicians in low resource settings for the management of open, chronic, or complicated post-traumatic and post-op wounds. These are my references. We are also publishing this paper and submitting it to the JBJS case connector. And thank you very much, and I'm waiting for any comments and questions.
Thank you very much. I think we will have Dr. Shearer's presentation first and then questions for both, if that's okay. Next is Dr. David Shearer.
Good evening. My name is David Shearer. I'm from the University of California, San Francisco, and I'm going to be talking about the timing of soft tissue coverage and open fractures. The learning objectives for this talk are to share with you a framework that I use for treating open fractures, which is clean, stabilize, and cover as soon as possible. And we'll talk about what that means over the course of this talk. Why is it important? I think everyone on this who's watching this is familiar with how common open fractures are and what a risk they are for major complications like infection and non-union. This is a young woman who came to my clinic about a year after injury with an infected non-union. She's in severe pain. She has a draining wound that gets recurrent infection. She's asking about getting an amputation and is unable to work or care for her family. Suffice to say, it has severe consequences for her quality of life. And I think we would all agree we would much rather prevent this complication than be dealing with it a year down the line, which is a much more complex problem. The bad news in that is that these injuries can be quite severe and you really have no control over that. But the good news is that there are aspects of treatment that have been shown to improve outcomes. And that's really what the clean, stabilize, and cover is all about, is trying to get the best possible outcome for every patient. So what actually happens when an open fracture occurs? When you have an open wound over a fracture, there are bacteria that enter that wound that are normally blocked by skin. They're planktonic bacteria initially, but they, over time, form attachments to the underlying bone and tissue and begin to grow and eventually form biofilm. And we know these latter phases as chronic osteomyelitis. And our goal is to interrupt this process well before it gets to that point. And the sooner we administer our treatment, the more successful we're going to be in achieving that goal, generally speaking. So let's get into clean, stabilize, and cover. Well, clean, I use that term very broadly to include all our effort to reduce the bacterial burden in the fracture site and decontaminate the wound. And the first step in that, as soon as the patient reaches the hospital, is to administer systemic antibiotics. And there have been numerous studies on this topic, but it's fairly consistently shown that the earlier the patient receives antibiotics, the lower the risk of infection is. And there's no real particular threshold, I think, to remember, other than the sooner the antibiotics are received, the better it is and the lower the risk of infection. The debridement is the second major component of the first step of cleaning the open fracture. And the timing of debridement is a topic of a great deal of debate. The classic teaching was that the fracture should be debrided within 6 hours. I think the reality is that there's no one right answer, and it depends a lot on the severity of injury. This image on the left of a type 2 open fracture is very different than the mangled extremity shown on the right. One nice study, I think, that kind of outlined this and matches my current thinking on this topic is that it really just depends on the severity of injury. So in this study, The top line there is represents really high-grade contaminated open tibia fractures. And among those patients, you see that with every hour of delay to surgical debridement, the risk of deep infection goes up markedly. So it's a really steep linear curve, a very steep linear relationship. In contrast, if you look at the lowest severity injury, which would be a non-contaminated, low-grade fracture that's not involving the tibia, the line's very flat, and you could delay 12 or 24 hours and really have minimal increase in the risk of infection. And I think this is the reality. And so when you're thinking about what's going to get you out of bed at night in order to breed an open fracture, the injury severity plays a big role in that decision making. But at the end of the day, the sooner you can get the debridement done, the less likely the patient is going to be to have a bad complication. In terms of the debridement technique, the most important principle is that you be thorough and systematic. The wound should be extended sufficiently to allow the bone ends to be delivered out of the wound, and then you have to systematically excise all dead and devitalized tissue. I teach the residents to use a system that goes from superficial to deep, treating the wound like a clock face and going from skin to fat to fascia to muscle to bone. And you really have to search in every corner for dirt and contamination. If there are butterfly fragments that don't have any attachments or blood supply, they should be removed, and you have to deal with the reconstruction later. This is what it looks like after some of that contamination has been removed. You see the numerous bony fragments and contamination that's been removed in a systematic thorough debridement. But the end result is a clean wound that's safe, in my opinion, for internal fixation and closure, which are the next steps in the process. So step 2 in the treatment of open fractures is to splint the soft tissues, stabilize the bone. This is a really critical part of open fracture treatment. If the bone is mobile right below that traumatic wound, then the risk of infection is higher. And this has been shown in animal studies and increasingly in clinical studies as well, that a mobile fracture site is bad for fracture risk. Internal fixation, I think, is generally preferable, particularly intramedullary implants. But you certainly have to consider external fixation if the presentation is delayed, or you have a really high-grade open fracture, such as a 3B or C fracture, or of course in cases where the patient's too sick to undergo a longer procedure. But in general, if you feel like you've adequately cleaned the wound, if you've got a really thorough debridement, internal fixation, I think, is a reasonable choice. Now that the bone is stabilized, you have to decide what to do with the wound. Historically, the treatment was to delay wound closure, to do multiple debridements. My personal opinion, and this is supported by a growing body of evidence, is that if you've gotten the wound thoroughly debrided and it's clean, then you can safely proceed with primary closure. And I think that the outcome has been shown to be better in these cases where you are able to achieve early primary closure. You want to cover that wound up so that you can't have new bacteria contaminating the wound. And in fact, in studies where they've cultured the wounds and done multiple debridements, the ultimate bug that grows out from the infection is not the one that grew out of the cultures, it's something else. And I think that just supports the fact that you've got to get the bone covered up again to allow your body to have its normal defense against infection. This is not just data from high-income countries. The SIGN nonprofit SIGN published results from their database on over 1,000 open tibia fractures and showed that in addition to injury severity, delay to surgery or debridement and delay to wound closure were both associated with higher risk of infection. What if you can't close the wound? Well, this has really been the theme of a lot of the talks today about how to achieve soft tissue coverage. But first, you usually have to temporize the wound. You can either use a wound vac, negative pressure wound therapy, or antibiotic beads. But really, my key take-home message from this talk is not how you temporize the wound, but the fact that it's got to be temporary. The definitive treatment has got to be some form of soft tissue coverage or closure as soon as possible. So this is what I'm talking about, a flap, like a rotational flap, like in this case on the top picture is a gastroc flap. The bottom right picture is a free flap. You may not have the microvascular capacity to do that or plastic surgeons to help with that. But being facile with basic rotational flaps, fasciocutaneous flaps, and procedures of that nature, I think is an essential skill for the orthopedic surgeon. And getting these flaps on early has been shown to really make a difference. So even with, negative pressure wound therapy and doing the wound vac changes in the operating room, there's still a 40% increase in infection per week of delay in flap coverage. So this is shown graphically here. You see that in the first week, the infection rate remains relatively low, but once you get beyond a week to coverage, the risk of infection goes up markedly. So just to conclude, just remember, clean, stabilize, and cover. Sorry, I got an ambulance going by. Clean, stabilize, and cover. And if you can get a good, thorough debridement and stabilize that fracture, then I think that the next most important thing is to get that wound covered up with a flap or closed as soon as you possibly can. Thanks very much.
Thank you very much, Dr. Scherer. So next, before the questions, we've had a change in the schedule. We were just going to do the post survey while all of the new information you've just learned is fresh in your minds, if that's okay. So I'm going to turn it over to Taylor and Dr. Woolley to just guide you through those questions, please.
Sure, thank you.
We're open for questions now for Dr. Scherer and Dr. Desjans and anybody else. Donc on est ouvert pour les questions maintenant. Est-ce qu'il y a des questions pour les deux présentateurs sur les deux sujets qui ont été présentés ou bien sur tout? Dr. Larson has a question. Dr. Larson? Donc là, voilà ce que vous allez voir sur pour le questionnaire. OK? Donc vous aurez tout simplement à remplir cette forme-là. C'est-à-dire la première question étant un patient de 19 ans sans antécédent qui fait une fracture ouverte gauche 3B des deux os de la jambe avec perte des tissus mous et exposition de l'os. Et on regarde la malléole interne. Après prise en charge initiale et ostéosyntèle, quelle serait la meilleure option de couverture osseuse de ces patients-là? Deuxième question, vous allez le voir aussi, donc vous pouvez les remplir. Taylor, I think we can ask the questions while they're filling up, and then we can kind of look, and now just say that after again and again because people raise their hands.
Sure.
Dr. Larson?
Je ne voudrais pas poser de questions, je voudrais seulement faire un petit commentaire sur la présentation du Dr. Scherer. Un petit commentaire peut-être que les résidents qui sont là et n'ont pas porté attention à cela. Le premier cas présenté est un cas d'ostéomyélite sur clou verrouillé, mais c'est un montage élastique, un montage qui n'est pas rigide, avec deux vis inférieures et une vis supérieure. Dans les cas présentés par la suite par le Dr. Scherer sur le traitement des fractures ouvertes, il a utilisé des montages rigides, avec un clou verrouillé, mais avec double blocage supérieur et double blocage inférieur, deux vis supérieures et deux vis inférieures, ce qui fait une grosse différence dans la conception même de l'infection. Parce que le principe de base de l'infection, du traitement de l'infection, est l'immobilisation. Ceci a été démontré depuis des temps. Et si vous faites un montage avec un clouage centromédulaire, rappelez-vous, il faut le faire de façon rigide. C'est simplement ce que je voulais dire pour pouvoir attirer l'attention des résidents qui regardent un petit peu les présentations. Merci.
Okay. You want to translate, Dr. Larson, just a few minutes? Et il y a le Dr. Desjans qui a une question que je vais lire pour lui dès que tu as terminé. Dr. Larson? So Dr. Larson was mentioning to Dr. Shear, to the residents specifically, that when you look at the first case that you presented with an infected non-union, one thing that he noted was it wasn't a static fixation. It was kind of an IM nail with a dynamic fixation. And when using the IM nail, specifically when using, for example, the sine nail, if you're only pulling one screw and not doing a static fixation, absolute fixation, you may lead to a non-union, especially if you already have an infection. So just to think about that when you're doing your primary fixation to avoid those kind of cases. Il y a le docteur Demong qui demande comment savoir quand faire le prochain pansement. So Dr. Demong is asking, I guess, Dr. Desjans, when do you know how to do the next wound care for your, when you're putting the vac? Dr. Desjans, tu peux répondre en français? Translate afterwards.
Ok, je vais dire ça en anglais après. Et bon, normalement, le Turtle Vac avait été construit pour être utilisé chaque 3 à 4 jours. Et par expérience, lorsque nous avons des cas infectés, je commence toujours à faire le premier pansement 2 jours après pour essayer d'estimer le temps de granulation, s'il y a une bonne vascularisation qui se fait, etc. Donc, il n'y a pas vraiment un nombre de jours spécifique, mais j'ai simplement gardé ce protocole avec de bons résultats. So the answer would be, the Turtle Vac was constructed to be used with a wound change every 3 to 4 days. My team and I, we use it for infected wounds. We do the first wound care 2 days after, but there's not a specific time to do wound changes. It's basically, it's based on whether you have adequate tissue granulation, if you have a ready for surgery wound, or if, well, you're satisfied with the wound. So that's
Une autre question, another question is, est-ce qu'un pansement ne retire pas le tissu de granulation s'il est fait trop souvent et ne retarde pas ainsi la cicatrisation? So, yeah.
OK. Donc, et pour le VAC, je ne sais pas si c'est pour le VAC ou un pansement régulier. Je pense que les deux, ça retire une certaine quantité de tissu de granulation. Mais avec le VAC, j'ai eu assez de tissu de granulation et à chaque fois que je fais le pansement, ça ne dérange pas vraiment et m'en plaît.
Okay, you can translate in English? Just for...
So, he asked if regular dressing changes can actually take off the granulation tissue. With my experience, either or can do that, regular dressings or VAC dressings. But I think that with the VAC, in my experience, the VAC produces so much granulation tissue that it doesn't really bother me to do it at that at that time.
Okay. Est-ce qu'il y a d'autres questions pour les panélistes? Are there any other questions or comments from the faculty who's there, or a commentaire pour les médecins de service, ou encore d'autres questions? Dr. Augustin is asking, is it obligatoire est-ce que c'est obligatoire après le VAC et d'aboutir à la greffe? So is it necessary after a wound vac to go to a skin graft?
Well, not necessarily. For the first patient, it was done at the University of La Paix. The patient decided, well, we left the VAC for the first patient until it was fully closed. It's not necessary to do so, but I think it reduces your hospital length when you're not doing a graft. So en anglais, en français, je pense pas que c'est obligatoire d'aboutir à une greffe parce qu'il y a certains patients qui ont eu une bonne évolution avec la greffe jusqu'à épithélialisation. Cependant, ça augmente la durée de l'hospitalisation. Donc, je pense que c'est important aussi de faire une greffe lorsque vous estimez que votre plaie est assez saignante et avec un bon tissu de granulation pour faire la fermeture.
Dr. Demang said, pour lui, ce qui caractérise le prochain pansement, c'est le carré de gaz sur la plaie. S'il est collé, c'est qu'il n'y a pas d'infection et donc il faut laisser. So leaving the gauze there as a trick for him. And one other question, Taylor, I don't know how we're doing on time. Je demande à tout le monde de continuer à remplir la forme, le formulaire. You can fill out the form for those who haven't filled up the form yet. Taylor, how are we doing on time?
We're doing great, yeah. And if they have questions, we can...
We have other questions on the chat room. So, une autre question, c'est what antibiotic give the best results to prevent the biofilm? So I think that's for Dr. Shear. To your knowledge, quel antibiotique donne le meilleur résultat to prevent that biofilm result? Or at least what antibiotics do you use?
Yeah, I mean, we tend to use follow a pretty standard protocol of a first generation cephalosporin for lower grade open fractures. Use a third generation cephalosporin for gram-negative coverage or higher grade fractures. And if we have some kind of soil or fecal contamination for whatever reason, then we'll do really broad spectrum coverage. In terms of, I don't know, that any one particular antibiotic is more effective in preventing biofilm. There are antibiotics like rifampin that have been shown to perhaps penetrate biofilm a little bit better than other antibiotics. There's an area that I'm actually really interested in is local antibiotic administration, either in a carrier like PMMA or even as naked antibiotic, just powder, because at really, really high concentrations, some antibiotics have been shown to more effectively penetrate biofilm. So that may be something that holds promise, but I think there's just not enough research on that. I hope that answers the question.
May I add one thing?
Go ahead.
That Dakin solution, that sodium hypochlorite, actually helps to break the biofilm and put bacteria back to their planktonic state. So as part of a whole dressing regimen, Dakin solution is actually very helpful. That's one of the reasons it works so well.
Donc, on a parlé de la solution de Dakin qui permet d'améliorer, d'empêcher la prolifération du biofilm. Et parfois même en mettant du Dakin sur ces plaies-là, le docteur a dit que ça élimine parfois même cette couche. Et le docteur Chiu dit essentiellement c'est le protocole standard, c'est-à-dire les céphalosporines de première génération pour les grades 1, enfin, et type A, type 1, et puis ensuite des céphalosporines de deuxième génération associées ou non à des antibiotiques de large spectre, genre gentamicine, si ça va, et c'est beaucoup plus infecté. Et aussi, il a aussi parlé de la rifampicine et comme étant quelque chose qu'ils sont en train d'utiliser aussi quand c'est à large spectre. Any other questions? D'autres questions? Je vous rappelle que le link, Kayla, can you post the link again just for them to have them because there are many questions on the chat room right now. Est-ce qu'il y a d'autres questions pour les deux patients, pour les deux présentateurs? I actually have a question. Dr. Demang Dr. Demang, who's head of UE, wants to say something. So Dr. Demang, go ahead. Vas-y.
Oui, bonjour tout le monde. L'expérience que j'ai pour les plaies, il ne faut pas faire trop de pansements. Et chaque plaie, on doit la regarder, comment te dire? C'est-à-dire que quand vous refaites le pansement, ce qui est important est de voir si le carré de gaz est collé ou pas sur la plaie. Si le carré de gaz est collé sur la plaie, c'est que nous n'avons pas réellement le film qu'il parle. Et à ce moment-là, tout est stérile. Il faut se rappeler que la cicatrisation se fait avec la peau qui est un épithélium stratifié, pavimenteux stratifié, et qui se desquame. Et si vous laissez la gaz coller sur la plaie, ça va finir par se décoller avec la cicatrisation. Mais par contre, si la plaie est infectée, on se rappelle que le pus est ostéolytique et ainsi la gaz ne va pas pouvoir rester collée. Et c'est à ce moment-là que je pense qu'on peut faire les lavages. Donc, pour moi, il faut regarder. Et le plus souvent, avec les plaies que j'ai à l'hôpital général, ce que j'ai pu constater, moins vous faites de pansements, et mieux ça vaut pour la plaie. Parce que le plus souvent, quand il y a du pu, le pu ne vient pas de la plaie, mais il vient de l'os. Donc, si vous traitez l'infection de l'os, automatiquement, vous n'avez plus de pu à sortir de la plaie, et ce n'est pas la peine de faire beaucoup de pansements qui, en fait, ces pansements sont extrêmement douloureux pour le patient.
So the technique that Dr. Deman mentioned is leaving the gauze on the wound. And basically, if there's pus coming out, it's not going to stick and you're going to see it on the gauze. But if the gauze is sticking and there's no signs of infection around that gauze, because of the biological responses, then he usually leaves that gauze on. And then when he takes it out, the granulation is pretty much done. And he has good results. Il y a une question du docteur Jean-Baptiste, another question. What is the best step when we have a pressure sore never fully healed instead of culture or covered by antibiotic? Dr. Desjans, I think that should be yours. When we have a pressure sore never fully healed instead of culture. Dr. Jean-Baptiste, vas-y.
Allô?
Yeah. Oui, on vous écoute.
J'aurais une question, bon, j'aurais des commentaires. J'abonde dans ce que le docteur Deman a dit, et je trouve qu'il ne faut pas exagérer avec l'antibiothérapie. Il faut lorsque vous utilisez trop d'antibiothérapie, vous détruisez et les bactéries qui sont bénéfiques et les bactéries qui sont maléfiques, et vous détruisez le tissu de l'articulation. Il faut mieux vaut toujours imbiber la peau d'antiseptique, ce qui serait bien meilleur. Maintenant, ce qu'il faut avoir, il faut être très patient avec les plaies, il ne faut pas paniquer. Et c'est vrai que même si lorsque vous avez du pu, alors vous pouvez utiliser un bon nettoyage, une bonne excision des tissus nécrosés, et même exciser un petit peu des os. C'est ce que je voulais dire. Et moi-même, particulièrement avec mes expériences, effectivement, je suis très patient avec les plaies et je ne panique pas du tout. Et parfois, je ne fais pas d'immobilisation directement, même au fixateur externe. Je reporte la fixation externe, et même quel que soit l'anesthésie-synthèse, à un petit peu de temps, peut-être même jusqu'au 5e jour et 10e jour même, quand le patient a commencé à avoir une récupération assez importante de sa santé et de sa santé en général. Et je crois que on devrait surtout avoir respecter certaines. Il faudrait être beaucoup plus patient avec les plaies et utiliser premièrement aussi les flaps. Il faut reporter les flaps, sauf si vous avez un type B avec l'os réellement à nu. Mais même encore de ça, même lorsque j'ai ça aussi, je considère qu'une fracture en trait transversal ou bien en trait légèrement oblique est stable. Donc, je pense que même on peut garder, ça peut-être pas, ça va paraître ancien, mais on peut garder la traction tout simplement, ou même un plâtre sans recouvrir la plaie. Alors moi, parfois, j'utilise des artifices. Je mets des cintres autour pour que la plaie puisse être à l'air même. Merci.
So Dr. I think that's Dr. Pellissier out of UE talking. He said that you have to be patient with wounds. So one thing that you do in a limited resource setting is to really look at how that wound is going to heal. He doesn't necessarily does the flap initially, and he's not aggressive with antibiotics as well. So he gives antibiotics, but he's not aggressive with it because you have to let the body heal itself. So that was his comment. Je vous rappelle qu'on a la forme à remplir pour terminer. Any other questions or comments? Est-ce qu'il y a d'autres questions, d'autres commentaires? Actually, I have a question, but I don't know since I'm translating and doing everything else. Dr. Shear, my question is, when did you decide not to? Vas-y, qu'est-ce que là?
Je voudrais placer un petit mot, si c'est possible.
Et Dr. Mathieu? So Dr. Mathieu is going to ask a question and I'll ask my question after. Vas-y, Dr. Matoli. Dr. Matoli, la communication est mauvaise. Si tu peux écrire ton message ou bien get a better signal.
Moi, je pense que plus on peut, en fait, plus tôt on intervient et qu'on est trois, oui, je pense que ça ne donne pas grand-chose. Donc, j'espère qu'on pourra m'écouter plus ou moins. Et je pense que plus on peut intervenir plus tôt et couvrir la.
So Dr. Matoli has communication problem, but what he's saying is he agrees the sooner you get to cover the wound, the better it is. That's what I got from the message. Dr. Matoli, tu peux écrire aussi si tu veux. Any other questions? On vous demande d'autres questions ou bien des commentaires. Je sais pas si the faculty wants to add a couple more questions. See the medicine service, Dr. Duffy. I think you were no, sorry. Good. All right, Dr. Shear. So
tu as oublié ma question, hein? J'ai posé.
Attends,
docteur Oulé, tu as oublié ma question.
Vas-y, pose, docteur Jean-Baptiste, vas-y.
C'est le docteur Jean.
Vas-y.
Alors, ma question, c'est à propos parce que j'ai eu une longue expérience avec c'est que je sais que et même si vous faites des lambeaux sur des expositions osseuses, ou même petites ou grandes, et bien à long terme, des fois, on n'a pas une cicatrisation complète. Et là, c'est un challenge pour moi. Et quand on n'a pas une cicatrisation complète, on a fait des prélèvements, on a fait de bons débridements, mais à la fin, on a vu sur beaucoup de patients, alors sur un nombre de patients, il y a des plaies qui n'arrivent pas à cicatriser complètement. En dépit de la couverture antibiotique, en dépit du débridement. Donc là, j'aimerais avoir des conseils par rapport à quelle est donc la meilleure.
Dr. Desjans, you want to answer? So Dr. Desjans is going to answer on French, and she's going to translate in English for the question that was asked.
Donc, ce que je comprends, c'est avec les flaps qui sont infectés. Donc, bon, moi, je pense que si je fais face à soit un ischio ou bien une plaie qui est terriblement infectée, comme l'un des cas que j'ai présenté dans l'article, si cette plaie ne guérit pas, donc je pense qu'un bon débridement jusqu'à avoir une plaie saignante avec l'utilisation de VAC, comme le docteur Duffy avait expliqué dans sa présentation que avec le VAC, c'est beaucoup plus rapide et ça pourrait promouvoir effectivement la granulation et aussi on pourrait essayer de tenter un flap. L'utilisation de flap, ça pourrait donner un meilleur, et ce serait meilleur pour surtout le patient, pour son retour à ses activités. Mais bon, si la plaie est assez superficielle, je pense que garder le VAC jusqu'à épithélisation serait aussi un plan à essayer.
You want to translate that a little bit in English to just have our English?
So I think that if you have really infected wounds, like the cases I've showed, if you have an adequate debridement and you have bleeding around the wound, if you use the VAC to promote granulation, I think it is also, and if you use a flap, it will actually heal better. If it's a superficial wound, I think that you can also leave the VAC for additional weeks and until the wound is completely clean. I had very good outcome with really infected wounds. So I think this is an alternative to use.
Okay. Taylor, vas-y.
Je vais poser une petite question.
Let me ask Taylor first. Pour demander à Dr. Taylor. How long, what are we doing on time? Are we good on time or we can still ask questions, Taylor?
Oui, j'ai une question à poser.
Vas-y.
Comment sont les patients au point de vue de la douleur? Parce que j'ai vu de magnifiques reconstructions, mais au niveau de la fonctionnalité et au niveau de la douleur, comment sont vos patients? Ils n'ont plus de douleur?
Tu veux one question now? You want me to...
Est-ce que c'est durant le VAC ou après le traitement?
Durant le traitement et après le traitement. Est-ce que le patient ne vient pas vous retrouver pour des douleurs résiduelles? Non.
Durant le traitement, ils n'ont aucune douleur. C'est juste lorsque je fais le débridement. Bon, c'est sûr, ça va être douloureux. Lorsque la pression est exercée au niveau de la plaie, c'est douloureux. Mais durant le traitement, il n'y a aucune douleur. Le patient ne se perd aucune douleur parce que c'est une pression assez faible. Et après le traitement, non. Aucun patient n'est venu pour une douleur.
Donc, il n'y a aucune douleur résiduelle. Après le traitement, ils sont indolores.
Ah, bon, ils ont une sensibilité, bien sûr.
Non. Ça fait mal ou pas?
Non, ça ne fait pas mal.
OK.
Je me permets de répondre parce que ça fait partie de mon pôle de patients aussi avec Dr. Desjans. Ces patients-là ont effectivement, et comme tout patient avec traumatisme, mais ils n'ont pas de douleur après ça. Ils ont une bonne évolution. En tout cas, la série que nous avons, ils ont une bonne évolution. So we're talking about Dr. Demang asked for pain. How are the patients after the VAC? Do they have pain? Do they have residual pain, as he asked? And Dr. Desjans answered that there was good outcomes and not so much pain using those kind of the VAC technique. Taylor, how are we doing on time?
Alors, je dois dire aussi que la douleur est un mauvais signe. La douleur est un très mauvais signe. En général, les patients, quand ils sont traités, après 24 heures, ils n'ont pas de douleur. Il faut bien préciser ça. Et alors, il y a une chose que j'avais dit, il faut aller, plus le traitement est précoce, mieux mieux les patients vont bien évoluer.
Okay. So Dr. Pellissier mentioned that he agrees the earlier you do the treatment, the better it is. Taylor, how are we doing on time?
We're technically over, but I also don't want to stop people from learning if they're in. I mean, that's what this is for. So if there's other questions, we're happy to take them. We would encourage people to still fill in the responses. We're still missing a bunch.
Bon, la conférence est théoriquement, le temps de la conférence est écoulé, mais puisqu'il y a tellement de débats and good questions, s'il y a d'autres questions, technically the time for the conference is over, but if we have other questions or comments, please feel free to do them, as this has been a very interesting debate. Il y a eu beaucoup de débats et de commentaires là-dessus. Il n'y a pas de débat?
J'ai une petite rectification.
Et docteur... Vas-y.
Rectification. J'ai dit que la douleur est un mauvais signe. En général, et après un certain nombre d'heures, de 24 heures, les patients à 72 heures, ils n'ont pas de douleur. Quand vous avez des douleurs, c'est que vous avez un terrible processus inflammatoire. Et je trouve aussi que vous n'avez pas peur. Je ne sais pas, je n'ai pas suivi les débuts, mais des présentations. Mais je pense que vous n'avez pas utilisé ce que vous faites des paramètres des phénomènes de laboratoire.
OK. Dr. Desjans, la question c'est pour toi, the labs. So he says, if the patient has pain after something, did you have any lab work done for those patients et les paramètres de laboratoire dans l'étude?
Can you repeat that?
Les paramètres de laboratoire.
I'm talking about the C-reactive protein.
CRP particulièrement.
Yes.
Oui, tout le CRP, au contraire, le CRP et les VS, bon, je suis désolée, je n'ai pas mentionné ça dans les slides, mais le CRP et VS ont été utilisés après chaque semaine. Donc, on a fait un CRP et VS au début comme référence et ensuite, après chaque semaine, on le refait pour voir comment le patient réagit avec les infections. So, the labs with SED rate, C-reactive protein were done initially for reference, and after each week, it was redone to control actual infection. I'm sorry, I did not mention it in the slides.
Okay. Let me see if there are any other questions. Donc, n'oubliez pas de remplir le link. On a presque terminé. Is there any other questions? Or Dr. Dyer and Taylor, I think we can safely say this. Go ahead.
Yeah, if we can just remind everyone to fill the link if they have a second. And I think we should also do a shout out to Christina for taking an idea of something that she had, and then she brought it to publication, and we were able to help her to do that. And so congratulations to her that she's been working on that and submitted that to JBGS and Case Connector, which is awesome. And congratulations to her. And if there is anyone on the call who's also have ideas like that they would like to work on, feel free to reach out to me, and I'm happy to help to guide in that process. So, but she did great work.
I'll translate that one because that's really important. On veut féliciter le docteur Desjans et son équipe qui a pu publier cet article-là dans JBGS Case Connector. C'est une invitation ouverte à tous les résidents et à tous ceux qui font des études ou des cas de série en Haïti. L'équipe de Taylor est disponible pour vous aider et vous accompagner dans toutes les études que vous voulez et publier dans les revues internationaux. It's open for everyone, so profitez-en. Je ne sais pas s'il y a d'autres personnes qui veulent faire des commentaires.
Great. So with that, we'll turn it back over to Dr. Dyer.
Dr. Dyer?
I just wanted to thank everyone for their terrific presentations and for your good questions and for joining us in our very first virtual meeting. This was very successful. And is it next week or the week after that we do it again?
Next week.
It's next week.
Next week. We'll see you all next week. Have a good night.
Voilà. Donc, merci à tous. Bonne soirée et à la semaine prochaine. C'était très bien. Et c'était un succès pour la première séance et à la semaine prochaine pour la séance de traumatologie. Bonne soirée à tout le monde et merci encore.
Thank you all.
Thank you. Bye-bye.
Thank you.
Thanks, everyone.
Thank you, everybody.